Almost by definition, I think the reason you're here is that you want to pursue an active lifestyle. It's obviously important. It's something I believe in, right? It's good for your heart. It's probably a great way to blow off some steam and deal with stress. And it's fun, right? And one of the things about remaining active is that you have to remain active, right? You have to prevent injuries. And unfortunately, shoulder problems are one of the most common things that go wrong. So with that as a bit of a context, my goal today is to provide you guys a little bit greater insight into how the shoulder works, how it goes wrong, and hopefully how to prevent it all, right? So I kind of have to apologize. I front-loaded this talk with some terms and anatomy. Hopefully we'll just get a baseline of some vocabulary and then we can move on from there. So the shoulder is actually a combo of three joints, right? There's the shoulder blade, or the scapulothoracic joint, and it's not a real joint. There's not like two cartilaginous surfaces rubbing on each other with the joint capsule. It's there's muscles actually on both sides of the shoulder blade, and it sort of floats, driven by the muscles on the chest wall. And then there is the glenohumeral joint. It's called the glenohumeral joint because the glenoid, or the cup, and the humeral head meet, and it's the glenohumeral joint. And that's probably what most people, when they say the shoulder joint, that's probably what most people are referring to. And then the last joint is this little one right at the top of your shoulder called the acromioclavicular joint. I'm going to get my pointer up here and working. There it is. So the clavicle there, also known as the collarbone, right? It meets this little expansion off the shoulder blade called the acromion. So where the acromion meets the clavicle, it's the acromioclavicular joint. I honestly can't say that more than a handful of times. I'm glad I got through it right now, right? So we call it the AC joint. So those are the three joints. And then the muscles that make it all move, the big ones are the rotator cuff, right? We've probably all heard of the rotator cuff. It's a series of four muscles. It starts on the shoulder blade. As they go out towards the proximal humerus, the humeral bone, they become tendinous. And then they insert all along the top of the humeral bone there, almost like a cuff of tissue. All right? The rotator cuff does a lot of great things for the shoulder. It assists in elevating the arm. It basically does the rotational movements. It resists the upward pull of the deltoid, which fortunately for today's talk, we don't have to get into because that's just way too much, right? But speaking of the deltoid, it is that sort of superficial muscle on the outside part of our shoulder, that fan-shaped muscle that most of us who have spent any time in the gym know pretty well, right? I mean, that's what we want to make nice look big and nice and well-toned, right? Fortunately for me and for you, the deltoid doesn't break down very often, so we don't have to talk too much about the deltoid. And then there's a whole host of muscles on your back and on your chest wall that we sort of collectively refer to as the scapular stabilizers or the scapular rotators. The big one in this sort of the cape distribution is the trapezius muscle, and there's a whole bunch of other little ones like the rhomboids and the serratus anterior. And those, like I said, we all kind of refer to as the scapular stabilizers, which we're going to talk about a lot. All right. So when you look at the shoulder joint, the glenohumeral joint, it's often referred to as a ball and socket joint, but it's really not, right? It's more like a golf ball sitting on a golf tee. That cup is not much of a cup. There's not much bony stability there. In contradistinction to the hip joint where there's a deep cup and the ball fits nice and well in there, right? So as a result of the lack of bony stability within that articulation, the shoulder blade has to do some pretty amazing things, and what it does is it rotates. So basically for every 2 degrees that your arm goes up, your shoulder blade rotates 1 degree, and that's basically to keep that glenoid, the cup, well balanced underneath the ball. So it's not the golf ball sitting on the golf tee, it's more of a dynamic analogy, more like a ball being balanced on the nose of a seal, okay? And what makes all that happen are those scapular rotators, okay? So, unfortunately, as you could probably imagine, this process breaks down, right? And it can be the primary process, it can be a contributing factor, and I see it a lot as sort of a secondary problem. Like you injure your shoulder, the shoulder gets stiff, the scapular rotators try to compensate, and you get this pain that goes up and down your shoulder blade. All right, we're not going to talk about that. We're going to talk really more about it as a contributing factor. And the most common way I see my patients get in trouble with their shoulder blade is that they sit all day long with their shoulders hunched in front of their computers.
Everyone just sat up a little bit.
Yes. Right? But, I do it, everybody does it, right? The problem is that the chest wall is somewhat curved, right? And the shoulder blade sits on that chest wall, and as you hunch forward, that makes it worse, and your shoulder blades protract and rotate down. And that just is a really bad place for the muscles around the shoulder blade to function. So let's try this quick little demonstration, right? If you hunch your chest and let your shoulder blades come down, now try to raise your shoulder up. Right? You barely get it past like your shoulder level, right? But if you sit nice and tall, pinch your shoulder blades back up, and now raise your arm up. Right? It's like some freaking trick, right? Isn't that really cool? So, anyway, so it's not just bad that you sit there all day in front of the computer like that, because we're not really asking our shoulders to work in that position. The problem is the more time you spend in that position, the more likely the soft tissues are going to become contracted in that position, and then when you go out to do your sports, your shoulder blade is going to remain in that position, right? So it's really not much of a surprise that if you spend 8 hours in front of your computer like this, that when you go to your rec league basketball game, that your shoulder hurts, right? So to deal with this problem, it's simple. Pay attention to good posture and work on those muscles, making sure that you're doing some scapular stabilizing exercises and fold it into your regular routine. And there's lots of ways to do this. I sort of think about scapular stabilizers as two different classes. There's the ones that make no sense whatsoever when you look at it, how to do it, right? And there's one of those there on that sheet. What the heck is that, right? And those probably are the better ones. Because they're a little bit more dynamic, yeah, right? Right.
They call it the rest picture or something that hands up against the wall.
Right. And then there's the row variants. And my favorite, she's got my favorite there. I think she called it the high row, where you're bringing it down like that. I think if you're doing a row to strengthen your scapular stabilizing muscles, that's the best bang for your buck.
And if I can just quickly interject, when you do the row to do that, you gotta set those shoulder blades first. Because half of us make it a biceps exercise, and great, we have strong biceps, but those aren't going to help our shoulder stability very much. So if you can kind of pack those shoulders and then pull down, you're going to be better off.
Right, and that's what I was just about to say. So no, that's great, that's perfect. Because what I see in the gym, and maybe because I used to do this, you want lots of weight and you want to big muscles, and you're going to get big muscles, but you're not going to get nice, well-toned, coordinated scapular stabilizing muscles. So you got to pay attention to form. I kind of visualize, I don't know if this fits into you, but I always try to visualize pinching a pencil between my shoulder blades. I don't know if that works for me. All right. So let's move on to a different problem in the shoulder, and it's most relevant to upper extremity athletes, baseball players, volleyball players, tennis players. I don't know if anybody's from Florida and knows high lie, right? So it's this abduction external rotation when you come through with force, anything like that, and the rotational velocities and the torque generated by the shoulder is really enormous. The numbers are just really hard to believe. And as a result of those rotational velocities and torque generated, there are many structural adaptations that happen to the shoulder, most of which are adaptive, and then there's two in particular that are maladaptive. So the one in particular is something called posterior capsular tightness. Every joint has a capsule. Think about it like a gasket. It sort of keeps stuff that's supposed to be in the joint, and stuff that's supposed to be out of the joint, right? And it has to be pliable enough to allow all the range of motion. And capsular problems happen in the shoulder. But for this, if you get tightness right back in here, and we think it's because when your arm comes through, it basically just keeps your arm from keep going forward, right? So that soft tissue contracts. And you might not even know that it's happening, that you've lost any range of motion, because the only way that you're going to notice it is if someone tests your range of motion, internal rotation, with your arm up here like that. So nobody really looks for that. Okay, but that's not where you get in trouble. How this causes trouble, when you bring your arm back, the ball should rotate and should stay well centered in the cut. If you have posterior capsular tightness, the ball rotates up and back, and puts greater stress on the labrum. And I'll talk about the labrum in 1 second. The other structural change that you see in athletes like this is something called pec minor tightness. So the pec minor is one of those pec muscles that nobody thinks about. It lives underneath your pec major, and it goes from your chest wall and goes up to this little knuckle of bone called the coracoid. It's actually an expansion off the shoulder blade. So when it gets tight, it pulls your shoulder blade forward and down, right? I'm already starting to beat a dead horse, right? So if you sit in front of your computer all day, if you throw a baseball and you get posterior capsular tightness, if you throw a baseball and you get a pec minor tightness, it's like a triple whammy. Of course your shoulder hurts, okay? So if you're that athlete, you want to pay attention to your posture, scapular stabilizing muscles, and you want to stretch your posterior capsule and stretch your pec minor. I like the sleeper stretch. There is some debate amongst people like us about the posterior, about the sleeper stretch, right? And believe it or not, people actually sit in rooms and drink beer and debate the sleeper stretch, right? That it's like the first one described. It's got the best literature behind it, and old fuddy-duddies love it. Like, I guess I don't have much gray hair, but I'm an old fuddy-duddy, right? The problem with it is easy to do wrong, and it's hard to teach. So the cross-body abduction one that's also on there is probably easier to do right and just as effective. We just don't have the literature to say that for sure. And then the two bottom pictures.
It's not a good one. You need a better one. He got a reject. Mike did.
Uh-oh.
2 rejects?
We can email them to you.
Yeah, I have them on email, but we can also print a couple more too.
Okay. So in the bottom pictures here are sort of 2 variants of pec minor stretches. What you don't see in this picture is this gentleman is laying on a very comfortable bolster, like a big rolled towel or like a small foam roll that sits right up their spine, so you're actually off the table, and you're using the body, your arm weight to sort of pull your pec minors down, right? This actually works a lot more effectively if you have a spouse or a partner or a friend or something that can then sneak up on you and push down on your shoulders, right? That works much better that way.
Whoops.
Oh my.
All right. So speaking of the labrum, right? This is the problem that I alluded to with posterior capsular tightness a second ago. The glenoid, right, is this cup portion of the shoulder blade. It's ringed by this sort of soft tissue structure called the labrum. The labrum, by the way, is Latin for lip. We just can't call it lip of tissue because we sound stupid. Right? We have to come up with some sort of Latin name so it justifies our bill. Right? So if you take away, if you have an artist, the biceps tendon comes in here and inserts at the very top of the cup, at the very top of the labrum. As a result of that biceps coming in, it's a sort of unique biomechanical area. If you have the artist take away the proximal humerus and get a more end-on look at the cup, you see this. So there's the cup, there's that fibrocartilaginous ring called the labrum, and this is the biceps coming in. All right. Now remember, if you've got posterior capsular tightness, instead of just staying well centered in the cup when you do this, you ride up and back, and that biceps literally pulls on the top of the labrum, and over time, repetitive stress, it just avulses the top of the labrum off of the cup, off the top of the cup, like the artist is trying to show you there. And that's a slap tear, the worst mnemonic in all of sports medicine. That's
Labrum, anterior, posterior.
Yeah, superior labrum, anterior, posterior. Like what the hell?
You like it? No one likes it.
I like my favorite's pasta tear, but we can come to that later.
Pasta tear.
So there's many ways that one can get a slap tear. The most relevant way is the way we just discussed. So what does that look like at the time of arthroscopy? You get, this is an arthroscopy picture. The camera's coming in from the back and the patient's laying on their side. There's the cup. You can see a little portion of the ball. This is that labrum. You can see the biceps coming in. And the surgical tool is getting in between the labrum and the cup and lifting up the top of the labrum, right? That's obviously an abnormal structure. The problem with slap tears is there aren't really great non-operative measures that directly impact the slap tear. I mean, you might be able to stretch out your posterior capsule, you might be able to work on your scapular stabilizers, but we don't have much to really impact the structural abnormality of the slap tear from a non-operative point of view. So a good number of times, if you can't get somebody back to their sport with some of those non-operative modalities we just talked about, people end up getting some sort of surgical treatment directed at their slap tear. Like in this picture, you can see a well-done slap repair. Treatment of slap tears is probably another 20-minute talk. So the bottom line is that if you think you are developing symptoms from a slap tear, an ounce of prevention is definitely better than a pound of cure. All right, so let's talk about the biggie, the rotator cuff tears, rotator cuff problems. Just for a real quick review, right? The rotator cuff is 4 muscles. They start on the shoulder blade. As they go out towards the shoulder, they become tendons, and they insert in that cuff around the top of the ball, right? So rotator cuff tendons are prone to injury. They don't have the most robust blood supply. It seems like some people are a little bit more prone to rotator cuff damage than others. As we get older, our rotator cuff tendons become a little bit more likely to become injured, right? And it might have something to do with some sort of abnormal contact with the tendon and on the undersurface of the acromion, especially when your arm's up above your head, right? Those are all those things that we can't change, right? When you're born with a funny shaped acromion, that's life, right? If getting older is a fact of life, it definitely beats the alternative, right? So, but then there are other things that we can change. And the biggest thing that we can change is our level of activity. More often than not, this rotator cuff problem represents an overuse problem. So if you start to have rotator cuff symptoms, it's a no-brainer. Just dial back your activities. Let your body's normal ability to heal this problem catch up to you. Once you start feeling better, you can get back to your sports. If, however, you can't do that, So I guess the other issue here is that rotator cuff problems exist on a spectrum. Right? It initially starts with some inflammation within the tendon. You might not even see any significant abnormalities with the tendon at the time of arthroscopy. It might look normal. And then that progresses to this, where the tendon is frayed, right? So this is the rotator cuff tendon, the top surface of it. It should be nice and smooth and glistening. It looks like this thing needs a haircut, right? As this goes down the path and it starts to involve more thickness of the tendon, you would describe this as a partial thickness tear. Some tendon tears either progress from that or start life as a full thickness tear. This is a small full thickness tear. So this is the tendon. This is the area of the bone to which that tendon should be attached. And clearly you should not be able to put this metal instrument between the two. Right? We also know, especially in the presence of symptoms, that a certain number of patients with small full thickness tears will progress and those tears will get larger. This is a fairly large tear. You can see the ball there. That doesn't project well, but believe me, the cup's out there somewhere. This is the area of the bone to which that tendon should be attached, and that's the tendon. Right? It's a really big rotator cuff tendon tear. Unfortunately, a greater number of those tears will continue to progress to the point where they are no longer fixable. This is a very bad picture. This is one of my least favorite pictures. This is an irreparable rotator cuff. You got a wonderful view of the cup, the labrum, and the biceps, and the ball, and the area to which that tendon should be attached, and that's the rotator cuff. And there's just a little bit of tendon, and then you see the muscle belly. And then as you go back further, it looks like there's this little interstitial split that sort of goes through horizontally through the tendon. So you've got sort of two leaflets. There's this top leaflet, and then there's this bottom leaflet. And there's just no way that you're going to get that edge all the way out there in a way that it's going to heal and going to represent a functional improvement for the patient. And even worse than this changes the function of the shoulder so much that you end up getting an x-ray that looks like this, where there is just no more joint space left between the ball and the socket. The center of the ball used to be down there, but now it's way up against the acromion. And the only way to fix this thing is with the reverse shoulder replacement. And that's not worth talking about today.
Is that kind of damage typical of an accident or repetitive use?
Well, both.
Okay.
What usually happens is someone has some sort of low-lying symptoms in their shoulder. Their function is relatively well maintained. Whether they've had a history of rotator cuff problems or not. Like I just saw, before I came down here, a guy 20 years ago, one of the gray hairs of the gray hairs, fixed his rotator cuff 20 years ago, one of the first arthroscopic rotator cuff repairs. He did great for 20 years, and then just a simple fall, his shoulder got a lot worse, and you got an x-ray and it looked exactly like that. Well, that didn't happen in the fall, right? So anyway, so again, this exists in a spectrum, and as one can intuitively understand that surgical intervention here is much more successful than surgical intervention here, right? And obviously the whole point is to avoid surgical intervention, right? So if you do have symptoms, you want to pay attention to your posture, get your shoulder stabilizer strong, work on rotator cuff strengthening. And how do you do that? There's a whole host of rotator cuff strengthening exercises. Actually, I think, I've never seen the one that Cindy got there before. I think it's a great one because you're actually working both sides at the same time. And a little side plank in addition. Like, I love multitasking, and that's the definition of multitasking, right?
In the city, you gotta come up with ways to get it done quick, right?
That's right.
Yeah, so that exercise is great because as you can see the pictures that Dr. Purchase has up there, you're getting that rotation. Some of you have done this exercise. And the other arm is firing that rotator cuff to stabilize the ball in the socket, which is the job of the rotator cuff, and work on those scapular stabilizers that he talked about front and back. So when you're in that fixed position with the arm, muscles on both sides of the joint are contracting, so there's better joint congruency and just better overall function. So that's our 2-for-1 exercise.
Yep.
Or 3-for-1 maybe.
And one of the nice things about this is you don't need lots of special equipment, right? You got the guy down here, I didn't go to TCU, but anyway, he's doing the cable crossover, but you just need some elastic bands, or maybe even a soup can, and even, with Cindy's, you don't need anything. So you can do it at home, you can do it on the road when you're on a business trip, and you want to pay attention to form because they are tiny muscles, and if you're not paying attention to form, you're not doing it right. And then if that kind of approach doesn't get you where you need to go, then you need to talk to Sydney or me, because you don't want to silently go down this path that we just showed, because you want to intervene sooner rather than later. And then this is the last thing that we're going to talk about. The AC joint, right, just for review, that's where the clavicle comes in and meets the acromion, right there. That little tiny joint right at the top of the shoulder is the only true joint that connects the whole arm to the rest of the body. It's hard to imagine, right? So the forces that go through that AC joint can be pretty high, especially if you're a manual laborer or some sort of athlete. So once you get past a certain age and you may be involved in some of these activities, you're going to have x-ray evidence of arthritis at that joint. Just like this x-ray here, clavicle coming in, there's the acromion. There is essentially no joint space left, there's no cartilage left in there. You've got these big bone spurs. The challenge is more people have x-rays that look like this and have no shoulder pain, right? So you got to make sure that you're treating patients, not x-rays. So what does this do? It basically causes pain right there at the top of the arm, and it radiates. Sometimes it radiates down the clavicle. And what really gets people into trouble with their AC joints? Weightlifting. It's the pressing movements, push-ups, bench press, military press. So if it's hard to imagine that little thing can get arthritic and cause so much pain. You could be a 40-year-old active person but have an 80-year-old AC joint, right? So if it hurts when you're bench pressing, just lay off the bench presses, let the shoulder catch up to you, and then get back to your activities. And if that doesn't work for you, you got to see me, because I got some moves that would take care of all that. All right. I think that's about it. So that is it. So I really appreciate you guys coming down. Obviously I'm a bit of a shoulder freak. I think the shoulder is an amazing biomechanical marvel. When you think about it, I'm surprised it doesn't break down more often than it does. We covered lots of ground. If there's any questions, I'd love to hear them.